In this video, we are going to explain the basic surgical technique and advanced maneuvers for performing endothelial transplantation. DMEK is the selective transplantation of endothelium, membrane, and Descemet's membrane, and it is indicated when there is endothelial insufficiency, whether primary or secondary. We will start the video with the preparation of the donor. There are numerous methods. We use corneas that are already prepared and stained with membrane blue dual. Here we have the preparation of a graft that already comes to us prepped from the eye bank. We place a few drops of membrane blue dual to stain the edge. With a little sponge, without touching the central area, we remove the dye, and after confirming that there are no breaks or tears, we proceed to trephination. In this case, we are using a Moria trephine, which cuts approximately 200 microns into the stroma. We place a few drops of BSS, remove the excess endothelium around the edge with forceps, making sure that the trephine has cut through all 360 degrees, and then we carefully remove the donor graft, trying to pull toward the periphery so that if there is any adhesion or tear, it does not extend centripetally. Once we have the donor, we stain it for 1.5 to 2 minutes with a solution of membrane blue dual. After that time, we rinse it and give it small jets of BSS to try to get the donor to take on a single roll or double roll configuration. Once we have it, we are going to aspirate it and insert it into the injection pipette, making sure that there are no air bubbles inside the circuit where the donor is placed. That bubble you see is a liquid bubble that is behind the donor, outside of the cartridge. There are ways to determine the correct orientation. Here we are making a triangular mark. Using a 45-degree blade, we are going to make an isosceles triangle that indicates the counterclockwise direction of the arrow, and once the graft is placed in its correct position, it should indicate a clockwise direction. There are other marking methods, such as marking with an F, by making a small trephination in the central area, drying it, and also using a hook to place it. We make a mark in the shape of an F so that we can see the correct orientation during surgery. Once we have it in place, we perform the trephination and then remove the donor as we saw in the previous case, always working under saline solution. The basic surgical technique includes preparing the patient, making incisions, performing an iridectomy, decimetorexis, inserting the donor, unfolding it, adhering it, and then the postoperative protocol, which is important. Here we have a case of a patient who is going to undergo a phaco DMEK, starting with cataract surgery. We have made 2 paracentesis incisions, then a main incision with the same blade. What I usually do is start with the capsulorhexis. Once the aspiration of the lens from the capsular bag is finished, we perform polishing, inject a hydrophobic intraocular lens, always avoiding hydrophilic material in these cases where we have to use gas in the anterior chamber. We constrict the pupil with acetylcholine. In cases of phaco DMEK, pupil constriction is sometimes not so easy. And then we are going to perform a peripheral iridectomy under viscoelastic, using a vitrectomy. Here we have the 23-gauge vitrectomy connected to the phacoemulsification machine, and with a single cut, we aspirate and then, by pressing the pedal, we make a cut to open this hole in the iris, in the lower area at the 6 o'clock position, being careful to avoid bleeding or touching the ciliary processes. Next, we will perform the decimetorhexis with a reverse Sinskey hook and forceps, usually under viscoelastic or air. Air makes visualization easier, although many times the chamber collapses and we will need to have an air chamber maintainer. Here we are performing the scoring or peripheral groove with the Descemet hexis hook, which is a reverse Sinski. It's a blunt hook to avoid injuring the posterior stroma. We gently pass at the level of the paracentesis and then tear the Descemet's membrane in a centripetal manner toward the central area, trying not to cause any tears or breaks that could occur, although sometimes it is necessary to remove it in several fragments. But we should try, little by little, to gather the endothelial tissue in the central area, which will make its removal easier. We tear in the area of the main incision as well to detach the endothelium from that area, and we position it in the central zone. And then, once we have it gathered, which is much easier to see thanks to the red reflex in the background, we use forceps to carefully pull it outward in order to remove almost all of the endothelial tissue. There will be an area left that we will remove in a second step using the forceps. Sometimes we pinch the posterior stroma and remove it completely, and again, with the forceps, we take it out in several attempts. The FAC, the injection of air bubble could make it easier to see retained Descemet's membrane fragments, especially in cases where visualization is poor. As tips for Descemet, we can make markings and perform it under mid-dilation. Here, for example, we have a case in which we are making a mark. Here we have a double marker with a diameter of 8 to 9 millimeters, which we are marking. I prefer to make the Descemet larger than the diameter of the graft we implant. As seen, double groove, central groove 8 millimeters and outer 9. Or we can also perform the Descemet with this Jones hook, following the edge of the dilated pupil after cataract surgery, before constricting the pupil and before performing the peripheral iridectomy. Here you can see how we do the scoring all around the peripheral area, the full 360 degrees, until we reach the incision, and then, using these centripetal movements, we gradually drag the Descemet's membrane and the endothelium toward the central area. We completely detach the endothelium and then, using forceps to pull from the most distal area with a downward movement toward the anterior chamber, we can fully remove the pathological Descemet's membrane and endothelium. Next, we are going to proceed to insert the donor. We use a glass injector. Personally, I use one from Guider, although there are other injectors available. And there are a series of tips that we will now go over. Here we have the injector, which is inserted through a 2.4 millimeters incision. We gently and slowly advance the graft to avoid an explosive entry into the anterior chamber and always avoid overpressurizing it, as this could cause the graft to be expelled outside. Here, little by little, we also try to unfold the graft, which will greatly facilitate the next part of the surgery. And here we already have it centered with a small air bubble that entered with the injector, which we then remove. We can also check under the microscope for the correct orientation of the roll. It is important to try to insert it in the correct orientation. Here we have a graft rolled in a double roll, where we can see its correct orientation using the Verospi sign. Here we are decompressing the chamber to make it easier for the graft to unfold. And here, at high magnification, we can see how there is a double reflection. This is what's called the Verospi sign. This tells us that the orientation is correct. Here, using the OCT, we can also see the double roll configuration that this donor takes on. Here we are using the irrigation cannula as an anterior chamber maintainer to make it easier to insert the graft. This will give us pressure and make the insertion easier. Then, once the pipette has passed the level of the pupil, we will slowly insert it, little by little, with small bursts of fluid until it is completely introduced. Once we have it inside the anterior chamber, we need to unfold it, and there are multiple maneuvers for this. You should always try to work with a flat chamber. Check the orientation, either with OCT or with the marks we made beforehand, and always use tapping techniques. There is a guide on a website where you can see what to do in each situation. Here we have a bouquet configuration that is easy to unfold. Let's position it. We're going to center it, trying to move it away from the peripheral iridectomy. Here we have the OCT. Let's visualize it, and you can clearly see that the double roll configuration is correctly oriented, so we just need to open up the peripheral folds. We do this by tapping maneuvers on the cornea with 2 cannulas. Little by little, we give these small taps to create fluid currents that help unfold the graft. Once we have it unfolded, we simply position it with gas. Here we have another case. We enlarge the anterior chamber with the maintainer, and once we've passed the pupil, we remove the maintainer and inject it. Here it is being injected slowly. There's also more membrane blue than usual, but again, we gradually withdraw the injector using the cannula we always have. It's important to have a cannula ready in your left hand. Here we've taken the graft out of the injector and we're going to depressurize the chamber to prevent it from being expelled. Little by little, we withdraw the graft. We depressurize the chamber, trying to open it to check that it is correctly oriented. We switch the syringe and injector to the other hand. We're going to aspirate the bubble. In this case, we're going to keep the injector plugging the main incision, and this will help us a bit with the graft unfolding using these small tapping maneuvers. Once we have it here, we simply remove it and then proceed as usual. It's a donor that opens easily. We have placed a suture in the main incision and then, with this cannula, we go over and under, checking, using the so-called Matsuri sign, that the graft is correctly oriented. In cases of an inverted donor, we have to reorient it, using short bursts of BSS that allow us to flip the graft inside the anterior chamber. Here you have a case in which I flipped it over and simply, by making small bursts and then decompressing the chamber, we can open it in the correct position. And then, afterwards, we gradually open it up. To adhere the donor, we inject air or 20% SF6, depending on each surgeon's preference. I usually leave it for between 30 minutes and an hour, and then we partially remove it. Here, we place the gas. In this case, I'm using 20% SF6 gas, with the graft remaining well centered. Normally, I don't pressurize too much. I like to maintain a physiological ocular tone, not cause hypertension as in the case of DSEK. Here you have another case of a patient with a failed DMEK, a 45-year-old phakic patient. Here we're going to perform a paracentesis and apply acetylcholine to constrict the pupil, since this is a phakic patient with a clear lens. We apply viscoelastic. We always use cohesive viscoelastic, never dispersive viscoelastic. Then, through this single paracentesis, we will perform the vast majority of the maneuvers. We perform the peripheral tear of the Descemet membrane to start the Descemeter hexis, both clockwise and counterclockwise, until we reach the paracentesis. Here there is a dense central opacity that will prevent us from having a good visualization of this maneuver, so we will gradually detach the Descemet in the entire peripheral area, bringing it toward the center, but not too much, so that our view is not blocked by the central opacity. Once we have practically and carefully detached the entire delicate periphery of the endothelium, we will then begin to gently pull it toward the central area, ensuring a smooth and controlled movement. We remove the hook and, in the visible area, we will grab with the Descemet hexus forceps, which are reverse forceps, and we will remove it from the central area using these maneuvers, moving it toward the nasal area. And these rotational movements, little by little and with patience, gradually pull all the endothelial and Descemet's tissue until it is completely removed. Next, we are going to perform an inferior peripheral iridectomy, as we mentioned earlier, using the vitrector with a single cut and an aspiration of 350. In this case, the vitrector was not properly primed, so we had to aspirate these small air bubbles again. We press the pedal again and make the opening in the iris. We check its patency and remove the vitrector. Now we are going to make 2 additional paracenteses, one in the nasal area and one in the temporal area, and we will use the initial paracentesis, enlarging it as an incision to insert the donor. Here we enlarge it to approximately 2.4 millimeters. It's a 2.2 millimeter knife and we enlarge it slightly. We are going to remove all the cohesive viscoelastic. As I mentioned, it is absolutely forbidden to use dispersive viscoelastic in these situations, since it would be very difficult for the graft to adhere to the posterior surface. We check that the graft is correctly oriented and we are going to enlarge the anterior chamber with the irrigation cannula. We are going to place the pipette outside, facing away from the pupillary opening, and little by little we will insert the donor into the anterior chamber. We are going to withdraw it by applying counterpressure with the cannula, and we will move it away from the peripheral iridectomy so that it doesn't open up in that area, where sometimes fibrin can form and cause the graft to stick at the site of the iridectomy. We place a suture at the main incision to prevent the graft from escaping during the maneuvers to move it. We are going to deepen the chamber so that the graft can unroll. We see that it is inverted, so we are going to flip it over. Once we consider that the orientation is correct, we will gradually decompress the chamber. We start to open the donor, centering it towards the central area, and once we have it here, we will decompress a bit more. We are going to keep opening it with these gentle compression maneuvers. We keep reorienting it towards the upper area. And once we have it centered, with this fixation maneuver using one cannula and tapping with the other cannula, we unfold it in the peripheral part, both in the 6 o'clock area and in the 12 o'clock area. The graft ends up slightly positioned towards the lower area, so it is necessary, with small tapping movements. We keep centering it on the corneal tissue. Once we have it perfectly centered, without peripheral folds, what we do is place a gas bubble to adhere the graft. Here you have the images with intraoperative OCT, where we can clearly see the orientation of the graft, which is placed in the correct position. Then we place SF6 gas again to adhere the graft to the posterior surface of the cornea. We make some small expression movements to try to remove, if there is any fluid left between the layers, to eliminate these small remnants of fluid that might remain. And finally, with the OCT, after an hour, we check that it is properly adhered. We leave the patient in a supine position for an hour in the operating room and then partially remove the gas. Here you have another case in which it was necessary to remove the corneal epithelium because the visualization was poor. You can see how it changes completely after removing the epithelium. We perform a paracentesis. At this point, we apply acetylcholine to constrict the pupil. This is a patient who had previously undergone cataract surgery. We apply viscoelastic. We perform an inferior peripheral iridectomy. Although the patient already had a peripheral iridectomy at 7:30, we prefer to make a wider one here to avoid pupillary block. Next, we proceed to perform the Descemet hexis, going through the inner lip of the phacoemulsification incision that had been made in the temporal area. And here we will continue up to the paracentesis. After that, we continue clockwise along the 9 o'clock area. We move the Descemet's membrane toward the central area, freeing it from the entire peripheral zone. With the forceps, we remove it in a single piece, carefully so that it does not fragment and we can be sure that we have removed all of the Descemet's membrane. We perform a paracentesis. We make a main incision of 2.2 millimeters, slightly enlarged. Using the irrigation/aspiration cannula system, we remove all the viscoelastic from the anterior chamber again and then proceed to inject the graft. The graft opens. Here, the chamber tends to collapse, so you have to be careful when removing the injector. We are going to deepen the chamber, which will make it easier for this graft, which tended to fold, to open up. We place a suture in the main incision, check with the OCT that it is oriented upside down, so we need to enlarge the anterior chamber and gradually give small, brief PSS flashes to orient it correctly. This patient had a deep anterior chamber. We are trying again to reorient it. It is completely upside down. Here we see its tendency to come out if we increase the pressure in the anterior chamber. Here it is with this enveloping configuration. Let's check it with the OCT. It's completely rolled up on itself. We're going to remove it from the paracentesis, where it had gotten slightly caught. And here, well, there are donors in which, well, it's necessary, donors or anterior chambers, where the behavior of the donor is more difficult to manage. Here we are centering it. It looks like here we have an area that's starting to open up on the right side, and with small taps, we're introducing fluid inside and opening up the double roll, which, as you can see in the lower OCT, is in a proper configuration, and it seems like we now have the case on track. It's not always like this. Here we're going to. With these two cannulas, we're going to hold it in place and try to open the donor towards the upper area. It doesn't have that tendency to move upwards and settle in the upper area, which prevents it. Since it gets into the angle, it somewhat prevents it from unfolding in the upper zone. We use small tapping motions, trying to position it, but we can see that we already have a taco-like configuration here, about 50-50, and we once again reform the chamber to give us space so we can move the roll more towards the lower area. Here we try to unfold it again. We keep trying to carefully and precisely open it in the lower area, but we clearly see that it's already completely inverted, as you can distinctly observe in the OCT, so we'll have to apply small, gentle flashes in this specific area again to effectively flip it over. Here, we already have it oriented correctly once more, but it persistently keeps rolling up on itself, which is a continuous challenge. Here, simply put, this is what we call the dance with the donor. Here we have it now. We fix it on the left side and we're going to zoom in. We decompress the chamber through the paracentesis and little by little, we start to unroll it, which leaves it in a more open position. The chamber is not completely collapsed. It was probably an eye that had undergone vitrectomy or had low vitreous pressure. Here we already have it open and correctly oriented, and we are going to proceed with the injection of gas to adhere the graft to the posterior part of the cornea. Not all donor deployments are easy. You have to be patient, try to manipulate as little as possible, but know all the maneuvers: tapping, unfolding, rotating the graft in the anterior chamber, using air in certain situations, and so on. The use of techniques such as increasing vitreous pressure with your finger by compressing the sclera, and so on. Here we are placing a bit of gas in the upper part so that it will later detach towards the lower part. And here, once we have the anterior chamber completely filled with gas, we have the patient lie on their back for an hour before they can go home. Afterwards, as soon as the patient gets home, what we usually do is have them position themselves. We have them spend a couple of hours lying on their back, 2 hours on their right side, 2 hours on their left side, and 2 hours sitting up. And we repeat this 8-hour cycle for about 4 days. We monitor with OCT on days 1, 3, and 5, and we do a reballing if there is more than 30% detachment or if there are central reballings. Our detachment rate is actually low, which is why I believe that when the technique is used properly, the success rate is high.